So in this brief video, we're just going to go over mean arterial pressure. So this is so relevant to our treatments. Our patients, whether they're experiencing hypovolemia, cardiogenic shock, and any other pathological disorder that could disrupt their blood pressure and overall perfusion status. So I know what you're probably thinking. It's like, why are you asking me to do one more vital sign? I already do a slew of them. There's more in the ICU and not in the pre-hospital setting. Well, technically they do it in the in-hospital setting. It is quite relevant, but we actually get this number. We just don't really pay attention to it. Whether we use the LP15 or Zoll monitors, it actually gives us this value. It's a low number beside our blood pressure that we just don't really pay attention to. Overall, mean arterial pressure is, again, more representative of the patient's perfusion status because it's the average pressure in the patient's arteries during one cardiac cycle. So it's truly a representation of their perfusion that gets to their vital organs, such as their brain, their heart, their kidneys, and their lungs. And this is all influenced by so many different factors. So if we take a normal patient's blood pressure, 120 on 80, systolic value represents the highest amount of contraction or force during the blood pressure cycle, or the ventricular contraction, then the diastolic value represents the minimum amount of pressure during the cardiac cycle. But if we have a patient's mean arterial pressure at less than 60, that's suboptimal. So that means they're not really perfusing their vital organs, and they probably need some therapies to bring it up to maintain that optimal hemodynamic status. When you look at most numbers in most literature, if patients have a mean arterial pressure between 60 and 65, that is optimal. That means they have sufficient amount of perfusion to their vital organs. So our mean arterial pressure is representative of actually our cardiac output. It also is representative of our systemic vascular resistance. So how much resistance specifically the left ventricle is probably contracting against. Obviously, if there's more resistance, they increase the workload of our heart, and that can lead to a variety of different diseases. So if you change any of those things, that can influence our mean arterial pressure by raising it or decreasing it. So if you lose blood volume, such as in trauma, that obviously could alter your cardiac output, and that obviously can impair your mean arterial pressure. See, if you lost blood volume and it drops, and your mean arterial pressure now is 52, obviously that's insufficient for your metabolic needs, and you're not perfusing well. It can also be dependent on the elasticity of our arterial walls, whether we're sympathetic nervous system innervated. So obviously the sympathetic nervous system increases heart rate, contractility, blood volume, hypertension. That obviously increases our mean arterial pressure. Inversely, such as you're experiencing neurogenic shock or spinal shock, lowers your blood pressure, lowers your heart rate, and overall leads to reduction in your mean arterial pressure. What if you have, again, vasodilation? That alters your systemic vascular resistance, so you increase the tank size, such when you have sepsis or anaphylaxis. So we have about 5 liters of us. It's fairly our vessels are fairly constricted in a normal state, but if you have sepsis or anaphylaxis, you enlarge the tank side to potentially hold 20 liters instead of 5. And you also have fluid leakage outside your vessels from the increased cell permeability. That impairs our ability to perfuse our vital organs. And of course, you lower heart rate. And if you're in a 3rd-degree block, that's going to impair your perfusion status. And again, if you're losing blood volume from a trauma, specifically like a pelvic fracture, where you lose up to 4 liters, that can alter your preload. And overall, that impacts your perfusion status. So you can look at any pathology that alters one or many of those things. But this overall extends to trauma patients, or cardiogenic shock for ACPs, for dopamine, and PCP AIVs for giving fluid therapy. Because even if the patient's blood pressure is 88 on 60, but they look like they're perfusing well, evident from good adequate skin color and their GCS15, they are still adequately perfusing at that point in time. And just because they meet the medical directive doesn't actually mean they need fluid therapy, because we know high and excessive amounts of fluid in trauma could potentially worsen their outcomes, increase morbidity and mortality. So we don't want to cause that collateral damage, and we always want to weigh the risk and benefits. In comparison, what if an ACP or PCP AIV or PCP in general just has a cardiogenic shock patient? What if their blood pressure is 86 on 50? It's like technically they can meet the medical directive for fluid therapy or dopamine, but they look like they're perfusing well, evident by the mean arterial pressure and their color and being GCS15. You can say I withheld it due to those reasons because we don't want to cause that collateral damage. Or overall, this video is more to give you more comprehensive info of a mean arterial pressure and actually apply it to different patients and give you that ability to make good clinical rational decisions based on the whole spectrum of the picture and is documented and treat accordingly. We're not asking you to do the equation, the monitor already gives it to you. It's overall just giving you one more tool to assess patients' perfusion status. Which